Hi guys, I've gotten a couple requests this weekend for a video on the transplant immunology material that you need to know for your hypersensitivity cases tomorrow. The majority of transplant immunology gets about basically avoiding an immune response. So we want to do things that will limit the amount of inflammation that a patient will experience following exposure to the graft. And then the reactions that do occur, how did they occur, and can we characterize the timeline, the scale, and the likelihood that the graft will fail? Okay, so we have two major types of transplantation, and you probably knew that before you even opened the notes. So you have your solid organ transplants. These are things, like your organs. These are hearts, lungs, um, kidneys, organs that you routinely think of going into failure, and then that can obviously be very severe for a patient who is, lacking a heart, obviously. So these would be solid organs. We can also transplant cells. So the most common explanation of this are bone marrow transplants, which are sometimes referred to as BMT, or hematopoietic stem cell transplants, which you'll sometimes seen written out as this, HSCT. And oftentimes a patient gets both. This is most often done for patients with some sort of leukemia, where we're actually just clearing out the white blood cells and creating a new white blood cell precursor pool. Because remember, your T cells and your B cells come from the common lymphoid progenitor, which is within the bone marrow. So why don't we really talk about blood when we talk about transplant? It is obviously a transfer of cells from one person to another, and there are types that are more involved with developing immune responses than is others, which you can plainly see within the material for this CBCL. The reason is that the mechanism behind blood kind of transfer, or blood transfusion is another way of thinking about it, is very different from what we think of with these two types of transplantation. So for one, the groupings of it are a lot more simple. It's just A, B, O, and then you have to know whether or not the person is D positive or D negative. These two are obviously a protein mismatch, in which case you're going to develop IgG antibodies, which can lead to a type 2 hypersensitivity reaction, which will be cytotoxic to the red blood cells, but it only affects the red blood cells. These three are obviously carbohydrates. So when we're thinking about them, we're only thinking about making IgM. And eventually, yes, that will still lead to activation of the complement system and cytotoxicity for those red blood cells. But again, we're just talking about red blood cells. We can replace them. So it's not exactly the same as when we're dealing with a rejected heart, which obviously would be much more detrimental. Okay, so within the transplant world, we just talked about kind of the two types of transplant, solid organ or bone marrow. Now we're going to talk about the four different types of transplant. And this actually begins to get at the concept of how we go about matching who gets what organs. Okay, so you have four different types. You have an autograft. An autograft is taking a piece of your body and moving it to another location in your body. The most common example about this, with this, is when a piece of vasculature is moved, say, from the leg to replace a piece closer to, say, the heart that is in danger of clotting. This is a fairly common practice. And in this case, because it's your own tissue, you're not going to have any sort of long-lasting immune response that will be made. You'll have some inflammation as a result of the injury for a short period of time, but it will resolve because all of this is your own tissue. There's no problem. Syngeneic is as close to autograft as you can get. Syngeneic literally means between genetically identical individuals. So really the only example of this is twins, since we don't clone humans. We do syngeneic transplants more in research, where we have genetically identical mice and we're able to transplant organs and whatnot between syngeneic animals. But certainly if you have a patient who has an identical twin, that is the holy grail of transplant matches. What's the most common form of transplant is allografts. It is the most common and also the most challenging of transplants that occur. This is basically from one individual to another individual within the same species who are not genetically related. The most common way this happens actually is with siblings. Siblings typically represent your best chance for a good match because you both got your genetic material from the same place and it's likely that you have some of the best overlap. That's not always the case. There are plenty of people who have siblings who it turns out that their sibling is actually a really bad match for them, in which case you actually look to the National Organ Donor Registry. And this will actually enable us to match people within a certain area of geography who have similar enough genetics that hopefully a graft would survive well. Xenogeneic is one species to another. This is not very common, so it's not something we're really going to discuss in depth, but an example of this would be like a pig heart valve placed into a human, something that was tried for a while. Now we have artificial valves, which are much more commonly used. So obviously the goal of any transplant is to avoid immune responses. And immune responses are really only going to occur to allogeneic or xenogeneic transplants, right? Because autografts are within you. Syngeneic is with your identical twin. So the only time you're going to have genetic disparity that can lead to an immune response is when you are getting a graft from an individual who is not genetically identical to you or from a different species. So in that case, we need to figure out a way to manage the immune response that could occur because the immune response is highly undesirable and could affect the function of the graft. And that's kind of a problem because our immune response in this case is doing exactly what it was trained to do. It is distinguishing self from non-self, mounting an effective innate and adaptive immune response, just like it would if it thought the organ was a bacteria, a virus, or a parasite. So we need to find a way to stop what normally we want it to do effectively. So there are kind of two different ways that our bodies treat transplants. There's a direct allorecognition and an indirect allorecognition. The direct allorecognition is actually mediated by T cells. So in this case, CD4 and CD8 T cells will recognize the actually intact MHC molecules of the donor cells. And remember, it really makes sense for CD8 T cells to be involved in this because MHC class 1 is expressed on all nucleated cells throughout the body. So that kidney that you just got from your brother has his MHC class 1 cells on it. And if it's not an identical match to your MHC class 1 cells, and unless he's your identical twin, it's highly unlikely they will be, your CD8 T cells are going to see this and go, I can't see antigen through this effectively, in which case NK cells will kill it. And then the other thing that will happen is that as these MHC molecules are degraded, they will be picked up and presented on the surface of the cell in another MHC molecule. And the CD8 T cell will be able to recognize it and go, nope, this isn't right, and it will try to kill it. And this is a fairly common practice. So even if you have matching MHCs, it could be any number of normal proteins, just normal kidney proteins that your body is recognizing as non-self. And this is kind of the driving force behind early acute graft rejection. So the T cells are recognizing these unprocessed allogeneic MHC molecules on the graft's antigen-presenting cells. The other way it can do it is an indirect allorecognition, and this is actually when it recognizes the processed peptide. So this is what I was saying when I was saying that it was going to process some of these molecules as it, degrades them, as proteins always do, and then present the peptide on the surface. That's an indirect mechanism. So you have uptake and processing of allogeneic MHC molecules by the recipient's antigen-presenting cell. So in this case, it's the recipient that has their macrophages breaking down some of those kidney cells and expressing the antigen on the recipient's own MHC with now the donor antigen in here and the T cell being specific enough to respond to it. And this is actually the driving force behind chronic rejection. And that kind of makes sense that this direct allo recognition of unprocessed molecules happens quickly because we don't need anything to change in the molecule for the body to see it. Whereas the indirect actually takes a little time to build up because we're priming the T cells and growing the immune response over time. Okay, so there are 4 types of graft rejection: hyperacute, acute, chronic, and graft versus host disease. So hyperacute rejection, the main thing you need to know is that it's mediated by antibodies that were already present in the recipient before the transplant took place. These are preformed HLA-specific antibodies that are against mismatched antigens. So remember, we're making a transplant from, say, me to my brother, and I don't have the same HLA type exactly as my brother. But let's say I have been exposed to those HLAs at some point in my life, and I made some antibodies to it. So now these antibodies are present. The antibodies will bind to the HLAs on my brother's cells. So here's here's the kidney that I got from my brother, and here are the HLAs, right, that are different from mine. And then I make antibodies to them, and I already had those before I ever got this kidney. And now these antibodies bind to it, and that kind of flags it for, say, a macrophage to try to come in and eat these cells using antibody binding, or if it's IgG, for an NK cell to come and try to kill the graft using ADCC, or for complement to bind and try to kill the graft in that way. Because there are so many methods for my body to try to kill this nicely tagged kidney with, my pre-made antibodies, this happens really, really fast, on the order of hours, and sometimes even as fast as minutes, because I already have everything present that could cause death. This will definitely be very significant. The events are typically irreversible, and the graft is lost, and it happens very quickly, certainly within a day. Acute rejection occurs by either those direct or indirect mechanisms. So direct, remember, would be unprocessed antigens on the donor APCs, right? That's what we talked about on the last slide. And indirect would be processed antigens that are being presented by the recipient APCs. So that's kind of the main difference between the 2 methods of rejection here. So in direct, the recipient T cells attack the allograft mismatched HLA antigens, causing inflammation and prompting B cells to make anti-HLA antibodies. So basically, if you think about it, this is the step, direct is the step before what I was describing over here, that you have these, what's up? So this basically is the process right before what happened up here with the antibodies that were preformed. So we're just making the antibodies that will eventually lead to the same outcome that we saw with hyperacute rejection. The nice thing here is that it takes a little bit more time, so we might be able to stop it. In indirect, the recipient's own antigen-presenting cells will process donor antigens or HLAs and present them to the recipient T cells to induce specific T cell responses. And what do I mean by specific T cell responses? Well, really, you should be thinking about Th1s, which means you should be thinking about interferon gamma and IL-12. And then it's just like any other immune response. This isn't special. Your body is still seeing something and responding to it the way it always should. Just in this time, we don't want it to. The good news is, because this takes a little while, acute rejections are often reversible. We're able typically to treat them if we know what's going on. And this is a lot of what anti-rejection or immunosuppressive therapy post-transplant is geared at. Patients take a lot of steroids and other immunosuppressive agents that you'll learn about in your second year to basically avoid transplant rejection by these mechanisms. This can be handled in a large variety of ways, and you can detect it really easily by looking at glomerular filtration rates, creatinine levels, proteinuria, detection of allograft-specific immune responses, and finally, if you're really worried, you can do an allograft biopsy to see what the level of inflammation in the graft is. Chronic rejection takes the longest, obviously, and it can occur in a variety of mechanisms. Certainly, it can occur the same way we just talked about acute rejection using T cells or antibodies, but it can also occur in kind of non-immune mechanisms that typically lead to fibrosis. And these are basically just changes in the graft that lead to the graft failing. It's a slow and steady loss of graft function, and eventually it will typically require retransplant. And there really aren't any treatments for chronic rejection. And eventually it'll lead to the loss of the graft. All right, and then the one that we'll talk about specifically, I think, in your CBCL is actually graft versus host disease. This is kind of an odd phenomenon, and it's something that specifically happens fairly frequently in bone marrow transplants and HSCTs, where about 20% of patients, even with a good match, will develop graft versus host disease. This is actually considered a type 4 hypersensitivity. So right away, you should already know that this means that T cells are definitely going to be involved in this. In this case, the donor T cells from the graft, because remember, the T cells come from this bone marrow, are going to attack the recipient. They're going to attack the recipient kind of throughout the body because they're recognizing the recipient's MHC molecules as non-self and mediating an attack. And it's an intense inflammatory response. So just as with other forms, there's acute GVHD and chronic GVHD. And this really just gets at how long the graft has been in the patient. So if it's within the first 3 months since the patient was transplanted, it's acute GVHD. If it's after the first 3 months, it's considered chronic GVHD. And this can be very debilitating, and it responds very poorly to treatment. And the most common reason that this happens has actually nothing to do with HLAs. So HLAs are your major histocompatibility antigens, or capital MHA. The GVHD that we see associated with BMT actually has to do with your minor histocompatibility antigens, or lowercase m HA. It's nice and confusing that way. But if you look at this, these are things that we don't necessarily expect to be a big problem, but can creep up and cause issues. And the most common example of this is HY antigen. And I say common in that it's the most common example of how this is taught. It's actually not the most common example of what leads to graft versus host disease, but minor histocompatibility antigens are, and male antigen is just one example that's very clearly understood. So male antigens are known as HY antigens. And what we find is that when a male graft is placed inside a female who has previously given birth to a son, that actually is more often likely to lead to graft rejection. And the reason is that this woman, when she gave birth to her son, probably developed antigens to, or antibodies to HY. And so therefore she has preformed antibodies, which can lead to at least hyperacute rejection, if not chronic, or if not acute rejection. That's kind of the most common reason this occurs. Okay, so with all of these mechanisms for rejection, how do we actually get a match? So recall that all of the HLAs that we've talked about, and I mean HLA, DP, DQ, DR, and A, B, and C, are all proteins. And if they're proteins, that means they can be an antigen. So MHC class I proteins are present on all nucleated cells, right? Every single cell in your body pretty much save red blood cells. These are called allospecific antigens. The MHC class II molecules are also proteins. These guys are found only on your professional antigen presenting cells. So macrophages, dendritic cells, B cells, and occasionally epithelial cells and fibroblasts will express them under significant stress. Well, what's a significant stress? Well, trauma, certainly, right? And surgery. Surgery is definitely stressful to your cells. So is disease. Now, remember, healthy people aren't getting transplants. You didn't just wake up today and you'd say, you know what I think I'd like? A new heart. I'm going to go get a new heart. No, you have a perfectly good ticker working right now. Why would you mess with that? People who are getting these have a lot of inflammation and trauma that's been going on for years and years. So that means that the fibroblasts and the endothelial and epithelial cells surrounding the diseased tissue is likely to be very inflamed and likely to be expressing higher levels of MHC class II than, say, you with your healthy heart. So if the antigens at the HLA loci are different between the donor and the recipient, then there's going to be an immune response. Even among close family members, these antigens are different, so not all family members are a good match. And then, as we mentioned before, there's the minor histocompatibility antigens. These are non-HLA specific antigens, so we'll make non-HLA antibodies. And the MHC class I chain-related antigens are another example of this. So we talk about MHC, and you've seen the structure. But there are some other MHC molecules that are associated with MHC that don't really change as much, and they can also induce a response. And those are considered minor histocompatibility antigens. Each of these can lead to a non-self response that could affect how long the graft lives. Now, here's where things get really confusing. For now, recently, I've kind of been talking about HLAs like, well, there's 6. There's DP, DQ, DR, and those are your MHC class II. And there's A, B, and C, and those are your MHC class I. And that's actually not accurate at all. I've been lying to you for weeks. What actually happens is that there's a whole host of different types of DP, DQ, DR, and A, B, and C. Okay, so if we look at the dad in this family here, we look at the father. He expresses many different HLA antigens. So in his repertoire of HLA for MHC class I, he has A1, A3, let's see, it looks like B8, B7, and that's it, okay? Oh wait, and then he has C's, and C's get an extra designation where you can have CWs, okay? So he also has CW1 and CW2. That's just for MHC class I. Then, if we look at his MHC class II antigens, he's got DR2, DR3, and then he also has DQ2 and DQ5. So that's a lot of variability just within that one person. And then we need to be able to match to that person. So literally kind of what you're doing here is counting the different HLAs that are similar with the ones that aren't. There are thousands of different HLAs on the HLA loci found in the human genome, and each is different. So we can do a molecular HLA typing and profiling using a potential donor's cells, like the blood or the buccal swab, and comparing that to the patient. So for example, this dad has 10 different alleles, right? And to be a perfect match for one of his children, they would have to have all of the same HLA antigens. And as you can see, looking at the kids, none of them is a perfect match. You have a couple that are pretty close, like for instance, child number 1 has exactly the same A1, CW2, B8, DR3, DQ2 as dad. But then when you look at the other chromosome, we've got A2 instead of A3, CW2 instead of CW1, B44 instead of B7. So you see there are these differences. When we look at this, families are still our best opportunity to find a match. And in fact, in 25% of cases where we're able to find a match within the family, typically the best bet is a full sibling. So if you look at these children, Child 1 is actually not a bad cross with child 3. They actually have a lot in common over here, but same with child 2. So this would be very difficult to kind of to decide which one we should go with. Now, if we complicate things even further, imagine we do have a full matched sibling who's a male, right? Let's say child 1 is a male, and our patient is, say, child 2, and she's a female who has had a son. It's likely she might have made antibodies to male HY antigens, these minor histocompatibility antigens. And this will affect the life of the graft, even if the major histocompatibility antigens are a complete match. I know, it's mind-numbing and very confusing. But if you think of it for the level that you guys are at now, of just kind of counting the MHAs and taking into account the patient's history, you're going to be able to come up with some good theories as to where a good match should show up and the types of rejection you might find. So what happens if you look at all of the siblings, or your patient is a single an only child, and you can't find a match in the family? Well, at that point, you're going to look to the National Donor Registry. The National Donor Registry is a pretty powerful tool for us to find organs for patients who are waiting for them. For BMT, HSCTs, you're normally doing this for a leukemic response. So not only do you need a good match, but you need a donor with a good T and NK cell response to kill potentially emergent leukemic cells. So you're going to want to be matched at all the HLA loci, which is not always possible to make the best match, but you're going to try at A, B, C, DP, DQ, and DR. And then you're also going to want to match based on whether the recipient has pre-existing antibodies against the donor's HLA antigens where they're mismatched. So in our previous slide, we had none of the children were a perfect match. But we can see, okay, is there anything pre-existing in our patient that's going to make them reject this donor that's like an 80% match with them? For solid organ transplants, we need a match that the donor does not already have antibodies to. That's key for avoiding hyperacute rejection. And we also need to look at recipients with high sensitivities to donors. So this would be something like women who have had multiple pregnancies, patients who have been transplanted before, and patients who have been on hemodialysis for prolonged periods of time. All of these patients are much more likely to have high levels of donor-specific HLA antigens, and therefore are much more highly susceptible to hyperacute rejection. Lastly, we need to look at what our waitlisted patients have going on for them. We need to make sure they're non-transfused, non-transplanted males with no pre-existing HLA antibodies. For these persons, getting a completely mismatched organ won't cause a hyperacute rejection. So we can kind of broaden the scope of potential donors because they are less likely to reject. At any given time, there are about 130,000 patients in the US waiting for an organ. And at any given time, we probably only have about 12,000 deceased donors who are available to give organs. It's a severe organ shortage, but it's the best we have. An alternative is a living donor, but obviously this excludes organs that people desperately need. Like, for instance, if you need both kidneys or both lungs or a heart, you obviously can't do that. I'm a big proponent of organ transplantation. You can save up to 8 lives through organ donation, and you can actually donate. You can impact more than 8 lives through giving of blood, eyes, and other sections of tissue. So if you're not an organ donor, please consider becoming an organ donor. If you live in Illinois, you can actually click this link right here, and it will take you directly to the Organ Donor Registry page. Good luck studying.